Hello listeners, a warm welcome to Views on Health. A great pleasure to have with me on the program tonight Dr. Dhakshitha Wickremasinghe, consultant surgeon at the National Hospital of Sri Lanka, and also Dr. Wickremasinghe is a senior lecturer in surgery, Faculty of Medicine, University of Colombo. A warm welcome to SLBC and to the program, Doctor.
Thank you very much. Thanks for having me.
And for the information of our listeners, as Dr. Dhakshitha Wickremasinghe's designation would denote, the focus is on surgery. And we thought it would be ideal to discuss how patients should prepare for surgery. Preparation per se is done by the hospital. The patient is also asked to do certain things, but importantly is the mental preparation for the surgery that the patient has to undergo. So preparing for surgery is our topic tonight. And having said that, may I hand the microphone over to you, Doctor, to tell our listeners what exactly one should do preparing for surgery. How much in advance would you need to tell your patient you're going to undergo this and this is how you should prepare yourself? And as I said, preparations is also done at the hospital because it is a surgical process there. But importantly, like I said, is that mentally, physically too, of course, the patient has been ready for the surgery that he or she is going to undergo. Over to you.
Thank you. In preparing to undergo surgery, whether it's major or minor, irrespective of how big it is, it's a big step. For us as surgeons, we see patients and who undergo surgery day in, day out. But for a person, it may be the only time they undergo a surgery ever in their life. So it's a big step, even if it's a minor surgery. So that alone requires a lot of mental preparation. And part of that is understanding why you're having surgery, what surgery is it going to be, how it will be done, and under what anesthesia. Those components would come into your mental preparation of getting ready to have surgery. Then the physical aspect you spoke about, you would need to think about fasting, what to do with your medicine, if you're already taking any medicine for any conditions, any special preparations, and the actual admission process itself. And these would be broadly the areas that I'd be talking about. The first thing about getting prepared is understanding what's happening. And there are a few things you must discuss with your doctor before you actually commit to undergoing surgery. The first is to understand why you actually need that surgery. I'm sure your doctor will tell you, but it's important that you, in your mind, is clear about what is going on. Sometimes we do surgery to cure diseases. For example, somebody with appendicitis would require surgery to take the appendix out, and that would cure them of the disease, and they will not get appendicitis ever in their life. Sometimes we do surgeries to prevent a complication of a disease. Some people have stones in their gallbladders, which are giving them minor symptoms, but nothing major has gone wrong. But we remove the gallbladder to prevent a complication from a gallstones. And sometimes we want the disease, in addition to cure, we want to stop the disease from progressing. Say somebody with a cancer, we remove the cancer to stop it from growing and spreading to other organs. So the actual intent of the surgery has to be communicated to you, and you have to identify and understand why it's done. And along these lines, it's also important that you know what will happen if you don't have surgery. There are certain situations where we won't offer you surgery, or we say, okay, the decision is up to you. For example, if a patient has a hernia, which is not giving them a lot of symptoms, we would offer them the option. You can have surgery, or we can wait. We call it watchful waiting. We can wait and see. So, of these options, why do we decide it, and what are the advantages of having surgery? It's very important that you know that. The next thing you must understand is, are there alternatives? So I said, okay, you can have surgery, you can we can wait and watch. Is there anything in between? For example, can we do anything with medicine alone? If we identify appendicitis early enough, we can try antibiotics and see if it settles. And that would maybe delay the need for surgery or completely remove the need for surgery. Or are there other techniques, like less invasive things? People are worried when we say surgery because people are afraid of having a cut. So modern medicine and the developments in surgery have given new options for things that would have historically required surgery. So for example, if you have a tiny growth in any part of your bowel, if we can reach it with an endoscope, we can remove it with the endoscope. Maybe 50 years ago, you may have needed surgery for that. So there are options that are outside the strict definition of surgery, which will give comparable results to the problem you may be having. So it's important that you discuss why you're having surgery, what will happen if you don't have surgery, and any alternatives to the proposed approach. Next, you need to know the type of surgery you might have. When I say type of surgery, broadly speaking, the classical types would be an open surgery, which is what you would see in a movie. You'll have a big cut in your tummy and the surgeon doing the surgery. And there are inherent problems that come with this approach. And as an alternative, we now have other techniques, scientifically called minimally invasive, but colloquially called laparoscopic or keyhole surgery. Why this is important is the preparation for this, along the things I will talk later, would depend on the type of surgery that you're having. There are also alternatives to these options. I've already spoken about endoscopy, but endoscopy is not only for bowel. You can have endoscopy to look at your urinary bladder, the uterus, and a lot of other organs. So in all these organs, there may be options to not have surgery and have any of these other techniques. And of course, there are other options. For example, things done using ultrasound, where you don't need a cut at all. So these would be the things you want to discuss, and of course, the benefits and the risks of what is proposed. First thing is that you need to know what are the chances that you will benefit. Sometimes we say, okay, for example, in appendicitis, if you remove the appendix, you will be cured and you will not have appendicitis ever again. But also in cases, say for example in cancer, we can't define cure that easily. So we say, how long will the benefit last? So we talk about success of cancer surgery in how many people would be alive after 1 year and 5 years after surgery. So do you have 100% chance of living up to 1 year after your surgery or up to 5 years after surgery? It's important that you understand what benefit you're getting. And it's important that both you and your doctor are on the same page as far as benefits and risks are concerned. Also, it's not only benefits. All surgeries and all interventions have inherent risks, and it's important that you understand the risks. When we talk about surgery, it's all part of the process we call consenting. Basically, when you express your consent to undergo surgery, we speak about these things, and we speak about common risks. Anything commoner than 1% of people undergoing surgery, anything that happens commoner than in 1%, we tell you. Bleeding, injury to any other organs, problems associated with the anesthesia, all of those things we will tell you. In addition, the surgeon will tell you anything that is less common but is likely to be more serious. If there is threat to your life, if there are more serious complications like say a stroke, the surgeon will tell you. So all of this is a part of the process called informed consent, and these will be discussed with you, and this helps you in preparing mentally to what you're going to undergo.
Thank you, Doctor, for that detailed and lucid introduction to preparing for surgery. And you said that now, if I can ask about the patient getting anesthesia, and you spoke about fasting. Now, what are the types of anesthesia? If you can just tell us that first.
Sure. So, anesthesia means basically relieving pain, but it is used in this context. Mainly when we talk about anesthesia and surgery, we are talking about general anesthesia. But there are lots of other types of anesthesia. So, for example, you can have, broadly speaking, you can have local anesthesia, regional anesthesia, and general anesthesia. Local anesthesia is when you have surgery for a small lump in your hand, where we give maybe an injection, maybe a spray, maybe a cream to numb that area. You're completely awake, you know what's happening around you, you only don't feel, the only difference is you won't feel pain where we're operating. You may have some sensations, but you won't have pain. That's local anesthesia. It's commonly done for minor surgery, like removing a lump or something wrong with your skin. The second type is regional anesthesia. Commonest is what's known as a spinal anesthesia, commonly given during, say, a cesarean section. But you also have the other things like epidural anesthesia, which also go into this group called regional anesthesia. Here, we are basically blocking the sensation of a set of nerves in the spinal cord. So, if we give an injection to your spine at a particular level, we can block you from feeling from your belly button downwards. So anything we do, whenever we do surgery in your groins, say for example a hernia, in your legs for varicose veins, or any other surgery, we can use this regional anesthesia. This blocks pain as well as other sensations, and sometimes you may get a weakness as well. The third type is general anesthesia, where we put you to sleep. So you're completely unconscious, you don't know what happens during surgery, and we give additional medicine to relieve the pain. So those are the three broad groups of anesthesia we use, and our preparation will depend on those.
Thank you, Doctor. Now, when you say fasting, is it the same process for all three, local, regional, and general, or it'll vary?
No. So the fasting varies a lot. I'll tell you why it varies, and then I'll tell you how it varies. Why do we keep patients fasting? Well, it's not to harass somebody, it's not to prepare somebody in that sense. It is because when you eat, everything you eat gets stored in your stomach for a few hours. It doesn't always empty at the same rate, and generally we estimate that it will take roughly 4 to 6 hours for the entire content to leave the stomach. Stomach is the second part of your digestive tract. The only part above that is the esophagus. Esophagus is a food pipe. The food pipe connects to the same place where your air pipe or the windpipe connects. If you don't fast, you may have food or liquids in the stomach. When you're under general anesthesia, the muscles in your body relaxes, and it's part of some medicine we give. So when these muscles relax, there is nothing keeping the contents inside the stomach from coming back into the esophagus. The esophagus does not have a valve. So anything that enters the esophagus can easily come up and go into the windpipe. And these can easily go into your lungs. In medical terms, we call this aspiration. Aspiration is a very serious condition. It can cause pneumonia, it can cause infections, it can cause changes in the lungs. So it is something we would like to avoid at all costs. So you can say that it is very important that you fast before general anesthesia. Along the same lines, if you're having surgery under local anesthesia, there is absolutely no need to fast, because you're awake, you're conscious, all your muscles and the muscles controlling these are under your control. So there is very little risk of things coming back up from the stomach into the esophagus and the windpipe. So the risk of aspiration is very small. So if the doctor has told you that you're going to undergo surgery under local anesthesia, we invariably say that you can eat and come, because it is, I suppose it's a cultural thing. People don't eat before they come for surgery. It's a good thing if you're having general anesthesia, but local anesthesia, you need to fast. So we say, okay, you can eat and come if you're having local anesthesia. If your surgery is going to be under regional anesthesia, it is slightly more tricky. If you're sure that it is going to be under regional anesthesia, there is no strict recommendation, there is no strict requirement for you to fast, because you will still be awake and your muscles will still work normally. But there is always the risk that your regional anesthesia may not work or may not be effective for the surgery. And there is a risk that we may need to convert it to a general anesthesia. If you're not fasting, we cannot convert it to general anesthesia because your stomach is still full. So we may either have to delay your surgery for a few hours or postpone it entirely. So because of that, we tell you to fast for general anesthesia, no fasting for local anesthesia, and we tend to treat regional anesthesia, as far as fasting is concerned, the same way we treat patients undergoing general anesthesia.
Thank you. That was important, doctor, and cleared a lot of, I think, doubts and sort of trepidation that people might have in sort of preparing for surgery and knowing the difference of the types of anesthesia and the process as far as preparing is concerned, physical preparation. Thank you. So going on from there, now we were focusing a lot on being mentally prepared. So do you give the option to the patient, or as a surgeon, would you say, I would recommend that you undergo this particular type of anesthesia? Of course, depending on the surgery.
Yes. So yes, it obviously depends on the surgery. Certain types cannot be done under other types. So for example, if you're having surgery of your bowel in your tummy, it is almost impossible to do it under spinal anesthesia or local anesthesia. So that would require general anesthetic. If it can be done equally well under all types of anesthesia, it would depend on a number of things. So in a hospital, if you want, now there are certain things that maybe in Western countries are done under general anesthesia, where we would do under local anesthesia, because that is how the healthcare system works. It is not only about the individual, but also about the healthcare system. So if it depends on the workload, depends on the facilities at the hospital, there are still certain places or certain healthcare delivery centers in this country who will not have facilities for spinal or general anesthesia. So the only thing they can offer would be local anesthesia. But if we will always give them the option, or give the patient the option within reasonable limits, that we may do it under general anesthesia or spinal or local. Certain things will, anywhere in the world, will only be done under local anesthesia because of inherent risks of the techniques. So local, of the three, anything has risks. Of the three, local anesthesia in properly selected patients would be the least risky of the two, because it only acts, as the name suggests, locally. There is nothing happening in the rest of your body. If you think about spinal anesthesia, obviously you're giving an injection to the spinal cord, and there are inherent risks involved with that. If it's general anesthesia, there are risks involved with that. Aspiration, like I said, is only one. There are risks of the drugs we use and a lot of other things. So on the balance of benefit and risk, certain things we would only recommend local anesthesia. Certain things, by the nature or the magnitude of the surgery, would require general anesthesia. Everything in between is a discussion between the patient and the surgeon.
So are there patients who would agree, for example, say local anesthesia you discussed?
Yes.
But come the time of the surgery per se, or just the day before, not at that time, can the patient retract, say, doctor, I'm not very comfortable, I'm nervous, I'm not very happy with this. why don't you just knock me off and do it? Kind of business. I mean, I just colloquially saying knock me off, meaning like put me under general anesthesia. I'm unaware. You can go ahead and have you come across these situations?
Definitely. There are certain patients who are scared, not only for local. So even things that we say we can do under spinal anesthesia, patients sometimes request general anesthesia. Sometimes these are due to misconceptions, and I often ask why they want to change their mind. This is very common when we talk about spinal anesthesia with young females. Somebody has told them that they've had a spinal anesthetic for their cesarean section 5 years ago and they're still having backache. There is no scientific evidence to show that spinal anesthesia causes long-term backache. It is very equivocal. There is no evidence at all. It is very anecdotal evidence that people talk about. So once they know this, and once we reassure that there is no scientifically proven connection between spinal and anesthesia and backaches, people often accept that there is no, and they're happy to proceed like we discussed with spinal anesthesia. Local versus general, yes. The main problem with local anesthesia is that you're aware of what is happening. So some people don't like it. So the alternative we offer is that we offer them to keep them asleep or drowsy so that they're unaware of what is happening. It is not a general anesthetic. All your bodily functions are still managed by your body itself. You're not connected to a machine, but you're only unaware of your surroundings. So a lot of people are happy with this. We give something to keep them sleepy for about 10-15 minutes until the surgery is over, and they're happy. And we've done the surgery under local anesthesia.
So that's like a sedative?
Yes.
Is it oral or is it another injection?
No, it is going to be an injection because we want it to act for a very short period. So it is going to be an injection.
Thank you, doctor. So preparation is there, and mental preparation, physical preparation. At the end of the day, what you require as a surgeon is for your patient to be still, so that you can carry out your surgery. Have there been instances where they have not been so? Even on rare occasions?
It's very uncommon for somebody, and it is mainly to do with poor selection of a patient for that type of anesthesia than anything else. But yes, so generally this is a problem under local anesthesia. Under spinal anesthesia, you cannot move your legs, so you cannot move around or fidget. And under general anesthesia, you're completely paralyzed. So in cases where patients are uncooperative or they're worried, it is not that they don't want the surgery done, they're just worried and they can't stop shaking. That is where we would use a sedative, like I said earlier, just to keep them sleepy or drowsy for 10-15 minutes until the surgery is over. And that is enough. Otherwise, it's very uncommon to not be able to complete a surgery because the patient, because of the type of anesthesia.
So end of the day, it is dependent on the type of surgery, obviously.
Yes.
And you take it from that point onwards.
Yes.
Because you cannot do a major surgery under local or regional.
Yes.
It has to be general.
Yes.
And you don't need to go for a general if it's going to be something that can be done in 15-20 minutes, half an hour perhaps.
Yes.
So the decision rests with the surgeon and the patient.
Yes.
Am I right?
It is always a collective decision-making process, and we always include the patient in this process.
And what is your take-home message, doctor?
So all advice, everything we've spoken about now is general advice. There will obviously be situations where the advice for you will be different, and always listen to what the doctor told you, whether it be fasting, how long you need to fast, medicine to take, medicine to stop, getting admitted, when to come to the hospital. Follow the specific advice you've been given. If you have any doubts, ask them, because it's important that you understand what's going on so that you're both mentally and physically ready to undergo surgery.
Just a rider to that question, there are certain patients whose pressure might go up or down, as the case may be, all because of nervousness.
Yes.
And mental stress.
Yes.
So then the mental preparation comes in.
Yes.
How long ahead would you want this mental preparation process to take place?
When we talk about surgery, there are emergency and urgent surgeries which we cannot postpone. So they happen then and there. When we talk about preparation, we're talking about surgeries that can be scheduled, what I call elective surgeries. So this happens at least from the point of scheduling your surgery, but maybe from the point of diagnosis. Now, when you're diagnosed with a certain disease, the doctor may tell you, okay, it is very likely that in the future you will require surgery. And your preparation starts from that point onwards. If you're unwilling to undergo surgery, for whatever reason, it is important that you communicate this to your doctor so that he or she may look for alternative options of management and not wait until the disease mandates surgery and you don't want to undergo surgery or you're not mentally prepared. So I think the preparation process starts from the point of diagnosis.
Thank you, Doctor. And on that note, we end this very interesting discussion on preparation for surgery. We place on record our grateful thanks to Dr. Dhakshitha Wickremasinghe, Consultant Surgeon, National Hospital of Sri Lanka, and Senior Lecturer in Surgery, Faculty of Medicine, University of Colombo, for being with us on the program and sharing your knowledge with us, your expert knowledge with our listeners. Thank you so much, Doctor.
Thank you for having me.
My thanks also go to Manjula Senviratna for technical assistance. I'm Fatima Razi Kadi saying good night and looking forward to your company next Monday, same time on Views on Health.